next presenter, Dr. Deepashri.
Good morning, everybody. My free paper presentation is on OCT features in type 2 Mac Tel, its relevance with clinical staging and visual acuity. So the term type 2 Mac Tel has been classically described as a disease of an elderly, which is seen usually bilaterally, and it is non-familial and idiopathic. It affects the macular Muller cells and the capillary network, and it is associated with changes in the inner and outer retinal structure and abnormal neovascular complexes. There are two broad classifications which are described by Gas and Blody based on only clinical picture, and Yanuzi based whether it is in a pre-proliferative or proliferative stage. The Mac Tel study project, which was initiated in 2005, is a collaborative study to determine to get a better understanding of clinical features of Mac Tel, and to study the natural history of disease and its pathogenetic mechanisms. The objectives of our study was to describe the SDOCT imaging features of type 2 Mac Tel and to see the relationship with the different clinical stages on fundus examination and visual acuity, and to establish a connection between SDOCT findings and disease pathogenesis. It was a retrospective observational study which was taken on a large cohort between January 2011 and December 2020. All the clinical records and SDOCT images of these patients were retrospectively studied, and there was a waiver of informed consent obtained. So based on the clinical imaging and blue reflectance imaging and SDOCT and fundus fluorescein angiography, the following study was done. All the patients with concomitant macular pathologies and dense media opacities were excluded from the study. So as in this picture you can make out, there are different features based on the SDOCT findings from the inner retina towards the outer retina. Initially we can see that there can be a loss of normal foveal contour and hyperreflective middle retinal layers, which is a classic finding of type 2 Mac Tel, and a small intraretinal cavitation, that is hyperreflective cavities can be seen along with hyperreflective middle retinal layers. Sometimes there can be intraretinal crystals which do not have classical backshadowing, and it can be associated with subretinal fluid pocket. Here we can make out there is outward turning of the inner retinal layers. Sometimes this retinal pigment epithelium clumps can get migrated to the superficial retina with classical backshadowing, and here you can make out that there is hyporeflectivity in the outer retinal layer suggestive of subretinal fluid, and here the classical ILM drape sign can be seen along with subretinal neovascular membrane, and in this there is hyperreflectivity in the inner retinal layers with subretinal neovascular membrane suggestive of retinochoroidal anastomosis. So these are all different varieties of presentation of type 2 Mac Tel on SDOCT. So here in our test we applied the following statistical test. The Shapiro-Wilk normality test was used to test the normality of the data tests, and Snellen's vision data was converted into logMAR. Different OCT imaging we had given the numbers and percentages, and the quantitative variables between the two groups we analyzed by Mann-Whitney U test for non-parametric data and unpaired T test for the parametric data, and chi-square test was used to compare the categorical data between the two groups. The correlation between different SDOCT markers and visual acuity were analyzed using Spearman's correlation test. So multiple variable linear regression analysis was performed between the visual acuity as dependent variable and statistically significant SDOCT features on correlation matrix as independent variables. So p values less than 0.05 were considered statistically significant. The results that were obtained out of this study was 212 eyes of 108 patients with findings of type 2 Mac Tel were included for analysis. The mean age at first visit was 62 years, and females were predominant in the study. all the patients were of Indian ethnicity, and 75 of our patients had diabetes mellitus also. And the mean logMAR was 0.4. So in table 1, the various SDOCT imaging features and visual acuity changes in patients with type 2 Mac Tel was seen, and it was seen that most common were irregularity of foveal contour, hyperreflective middle retinal layers, and hyperreflective retinal pigment clumps. So the OCT features noted in different clinical stages of type 2 Mac Tel based on gas and body classification. We saw which clinical findings seen on which findings were seen on SDOCT and how it correlated with the gas and body classification. Similarly, it was also compared with the Januzzi's classification. So in non-proliferative clinical staging, we saw that the most common SDOCT feature was hyperreflective middle retinal layers, followed by hyperreflective inner and outer retinal cavities and ILM drape sign, and outward bending of inner retinal layers. In proliferative stage, the foveal contour irregularity was common, followed by hyperreflective retinal pigment clumps and presence of subretinal neovascular membrane or RCA. So in addition, what was seen was 25 of these eyes showed disparity between the clinical staging and disease on retinal examination and SDOCT features. So these were classically missed by gas and body classification or Januzzi classification. So the other analysis, when we went through the entire analysis, we got to know that most of the patients had hyperreflective middle retinal layers, and the proliferative stages had foveal contour irregularity and hyperreflective RPC and presence of subfoveal subretinal fluid. And foveal contour irregularity correlated with the poor visual outcome with outward turning of inner retinal layers and hyperreflective RPC, and poor visual prognostic factors in proliferative stage were foveal contour irregularity and hyperreflective retinal pigment clumps.
You finish off, your time is